Hello, everyone, and welcome. It's my great pleasure to introduce our speaker, Dr. Dan Vena, who's going to give us a talk titled Non-Invasive Estimation of Site of Pharyngeal Collapse. Dr. Vena completed his PhD here at the University of Toronto and at KITE, working with Dr. Azadeh Yadullahi, studying the pathogenesis of OSA, obstructive sleep apnea, from fluid shift. In 2018, he started a postdoctoral fellowship at Harvard Medical School in the sleep disordered breathing lab, working with Dr. Andrew Wellman, where he focused on developing PSG polysomnography airflow-derived estimates of the pathophysiological traits of OSA, such as pharyngeal collapsibility and site of collapse, and applying them to the prediction of treatment response to non-PAP alternatives such as mandibular advancement devices and hypoglossal nerve stimulation. In 2021, he took a faculty position at the Harvard Medical School, where he's continuing on this line of research. Please join me in welcoming Dr. Vena. And as a suggestion, those of you joining online, you can type your questions in the chat box, and he will answer at the end. Thank you.
That's great. So I'll use this mic here. But this one's off, right? Okay. All right, thank you. Thanks for the introduction. And nice to be back. I did my PhD here, so the opportunity to speak here is great, and a good opportunity to come back and see some familiar faces. So today I'm going to talk about some of the work I've been doing on the site of pharyngeal collapse, and specifically, developing methods for estimating the site of collapse non-invasively. I recognize that there might be a more general audience tuning in, and so I want to just do a very brief crash course on what sleep apnea is. So, generally you have this is a situation of a normal breathing person with an open airway. What can happen during sleep is that the airway can collapse, the tongue might fall back and collapse at the tongue or the soft palate, and that's going to cause you to stop breathing or have reduced amplitude of breathing. And so you see here, this is basically an airflow signal here. As well as a SpO2 signal. Let's see if I can get my pen here. An SpO2 signal here, and so in an airflow signal, up is inspiration, down is expiration. So this patient's breathing in and out, and what you'll notice is they have a stable breathing pattern, which represents an open airway. So this is just what normal breathing looks like, and it comes with a stable oxygen saturation. So this person does have a low oxygen saturation, but it's not dipping, is the point. And so, in a sleep apnea patient, what's happening is your airflow is actually, dropping substantially. So you can see in this patient, basically, there's no airflow, and as a result, what's happening is they're, at certain points, when they have these cessations in airflow, their brain's saying, okay, wake up and take a few big breaths so you can get that CO2 out, get the oxygen in, but then, they fall back asleep again, and then they wake up again, and they take a few big deep breaths, and with that comes oxygen desaturation. And so, you can see this patient having an oxygen desaturation caused by the fact that they're not breathing. And so, these drops in airflow, these arousals from sleep, and these oxygen desaturations are bad for health in various ways. And one in particular is that frequent awakenings during sleep can lead to excessive daytime sleepiness, and then, repetitive oxygen desaturation and sympathetic excitation. That as a result of that, both of these can contribute to the pathway of to cardiovascular disease. So this is a big oversimplification, but that's the general idea. And how do you treat sleep apnea? So when you get sleep apnea, generally you're prescribed CPAP to treat your sleep apnea. The issue is that about half of users are non-adherent to the therapy. And so the idea here, CPAP, I should describe what it is. It's basically positive airway pressure. So you inflate the airway like a balloon, and you prevent it from collapsing. You have to wear this mask. People don't love it, so about half of them stop using it. And so it's important that we give this 50%, this other group, or even people that are wearing it reluctantly, an alternative for their therapy, for treating their sleep apnea. There's a couple very popular non-alternative or non-PAP alternatives. One of them is on the left here is mandibular advancement. So you can see this figure right here. The patient is, so the mandibular advancement figure on the left, the patient has a blocked airway, And what's happening is they're not breathing, and if you put this appliance in their mouth, you're going to move the lower jaw forward, you're going to open space behind the airway, and they're going to be able to breathe again. So this anterior movement of the jaw is opening anterior space behind the airway. There's a hypoglossal nerve stimulation. It actually works in a very similar way. It's just a different mechanism. So you have this signal generator that attaches to the hypoglossal motor nerve, and that stimulates the tongue to protrude anteriorly. So your tongue's protruding anteriorly, and again, you're in a similar way, you're creating space behind the airway. And so the big thing about those treatments is that they are considered site-specific. So you can imagine that, if you have a type of collapse that's going to improve by moving everything anteriorly, you're probably going to benefit. But there's other types of airway collapse that are harder to treat with those particular therapies. And identifying those from the outset is important for knowing, who you can give that therapy to, or even, say, okay, don't even go to CPAP, you can just get this alternative therapy instead. So identifying those patients is important. And so there's three things I want to talk about in terms of the site of pharyngeal collapse. So first is where along the airway is the collapse occurring? That's an important aspect. Is it the soft palate? Is it the tongue? What's the direction of the collapse? So the airway can collapse sort of anteroposteriorly, so in and out of the face basically, or it can collapse laterally, so in this direction. You can also get a sort of concentric type collapse, which is like a tube collapsing in on itself. And so knowing that information is important for describing the pattern. And then there's severity, so you can have partial collapse or complete collapse of the airway where you're having no air. And so, one of the things that I'm hoping to sort of, put out there is that you might learn about, what the site of pharyngeal collapse is, and then, we'll talk about the cutting edge in terms of the non-invasive estimates, but even just taking away from this talk, how the airway collapses, I think is an important piece of information to glean. So we're going to talk first about the site. So you have the two general areas of the airway, the velopharynx and the oropharynx, that we're mostly concerned about in terms of where the airway can collapse. So, this is the nasopharynx up here in the nasal part. I don't know if my laser pointer is showing up, but it's okay. And so, here we go. There's the laser pointer. Yeah. So you have the nasopharynx up here, but that's not really an area of issue. So you have the velopharynx, and that consists of the soft palate. That's one area where the airway can collapse, and so you have, this piece of the soft palate can fall back into the airway and obstruct the airway. You also refer to this as the velum, and we're going to talk about something called the vote score at some point, and this is the V in vote score. In the oropharynx, you have the oropharyngeal lateral wall. So now, when I'm showing you this view here, this is actually the view that an endoscope would give you. So your scope would come in this way, right? Come in, and then so you're coming into the airway this way, and if you then look at the view this, you turn the scope and look at the view this way, you're going to see this is the view you're going to get. This is the endoscopic view of the airway. So down here is the soft palate. Up here is the posterior pharyngeal wall. Now, when you bring the scope a little bit deeper into the oropharynx, now you're staring at the base of the tongue. But what we're looking at here is the side walls of the pharynx. And so the side walls can actually collapse laterally, and that's another type of collapse that you can experience. If you take the scope just a little bit deeper and look even closer at the base of the tongue, this is another area where a collapse can occur. So you have tongue-based collapse. And then, you take the scope even just a little bit deeper, and you can look at this piece of cartilage right here. It's the epiglottis. Some patients, that can become a little bit floppy. And when you get negative pressure in the airway from taking, a deep breath against a collapsed airway, that negative pressure can suck the epiglottis shut. I'm not going to talk too much about it. It is a more rare site of collapse, but it's an important, component of airway collapse. Now, when we talk about the direction of collapse, it very much does go hand in hand with the site. So it's the velum really that you get this variety of directions. And what I'm going to do is I'm going to show a few videos so that I can try to demonstrate all this. So that the scope is sitting right here. The scope, you can see on that figure on the left, it's sitting right at the, yep. Oh, I haven't started the video yet. Sorry, it's okay. The scope is, when I start the video, you're going to see the scope. I'm just orienting you right now. Scope sitting here. You're going to see a view of the pharynx. You're going to see a view of the pharynx that looks like this, and it's hard with the laser pointer. Okay. So we're going to go in through the nose. This is just to get you oriented. I guess I could take my mask off, right? So we're going through the nasal cavity. This is the inferior turbinate. And then we're going to look at the back wall of the pharynx. And so now this is the end of the nasopharynx. Now we're in the velopharynx, and we're looking at the, that there. I mean, unfortunately can't pause it with this view, but can I do that here? No, that's the timer. So yeah, I can't scroll through it like I can with when I do it otherwise. But what you were looking at there was the velopharynx, and we can just pretend that this is what we saw. And the idea here is that you have it looks like a clamshell. So this is collapsing in the AP direction. It's coming from this side, collapsing to this side. And so the idea is that that's important that's in the AP direction, because if you want to treat this patient, you think you want to just pull everything anteriorly. Now this is just an example. This is the airway. We're going to stare at the same spot a little bit more. So you can see this oval type shape, and that oval shape is telling us it's AP, and there's a little bit of snoring happening. We're looking past the velopharynx just because that's what the surgeon wanted to do at that time. And now we're looking at the tongue, but not really talking about that at the moment, but just talking about mostly the velopharynx and the fact that everything happening here is in the AP direction. I want to contrast that to a concentric type collapse. So the scope's in the same area, and now you're going to see the airway looks substantially different. So the scope is in the same area as we were before, but now you can see it's like a little triangle or like a little circle. So you're getting collapse in up and down, and you're getting collapse side to side. So you can imagine if you pull this patient's jaw anteriorly or you pull their tongue anteriorly, it's not going to do anything to that lateral component. So a very nice example of how you get two very different types of sleep apnea in ways that would be otherwise impossible to see unless you had this scope. These are a little bit easier to understand. This is the tongue. So we're in the velopharynx right now. We're going to peek behind the soft palate and look at the tongue. This is the tongue. He's got a little bit of space there, so you might think, okay, he's got a big tongue, but maybe he can breathe just fine. But this is what happens later on in the study. His tongue falls even further back. He's got this tiny little air. This is his airway. This is what he's trying to breathe through. Tiny little airway that he's trying to breathe through. And as a result, if you looked at his airflow, he has obstruction. And I just want to contrast that to what an airway looks like when there is no tongue. So we're going to peek past the soft palate. We're going to look at the tongue. This space right here, I need a laser pointer. The space between the tongue and the epiglottis right here, that's telling us the tongue's not that far back. In this patient, if you had his tongue far back, his tongue would be sitting up here. But actually, his tongue is sitting down here. So this patient is you would say, minimal tongue involvement. And the next thing is oropharyngeal lateral walls. So again, to get you oriented, we'll do the whole journey. We're going in the nose, through the inferior turbinate, and we're going to look at the back of the posterior pharyngeal wall, and then we're going to go just a little bit deeper. We're going to go just to the border, right where the soft palate ends, and we're going to even see a little bit of the tongue. But you can see right now he's got that circular velum. It's not a clamshell. It's more of a circle. So there you can tell right away there's going to be a lateral component to this guy's collapse. And if you take a close look at where the snore is actually happening, very distinct sort of slit-like look where it's just going from left to right, collapsing laterally. So again, you pull this guy's airway anteriorly, I can't imagine that you would treat this person's sleep apnea. There are potential mechanisms, but to oversimplify, it's very unlikely you're going to treat this guy's sleep apnea by pulling his jaw forward. Epiglottis collapse, as I said, this is just for the sake of completeness to show you everything. But this is that's his tongue, and we're going to look past the tongue, and we're going to look now deep into the airway at the epiglottis, and you can see his epiglottis is sticking to the posterior pharyngeal wall. He's trying to breathe through. This guy's trying to breathe through a little tiny hole on the side of his epiglottis, and if you see his airflow, which is not here, you can actually see he does get air, but ultimately this guy's got obstruction, and so treating this is tricky. There are some surgeries, and positional therapy is said to potentially treat this, but this is a classic epiglottic collapse. So hopefully that's clear, and hopefully you guys got a little bit of an idea of what the airway looks like in the different ways in which it can collapse. I also mentioned that the severity of obstruction is important. I won't really show that because it's fairly obvious. You can have an airway that's got a little hole, or you can have an airway that's completely occluded. So that's the difference between partial and complete obstruction. All of this adds together to how you score the airway. So we'll score this airway together. So this guy's got, we're in the oral pharynx, we're looking at his tongue base. The tongue looks to be taking up a lot of real estate, probably pushing the soft palate against the posterior pharyngeal wall as well. So you'd say, okay, soft palate snore, but the tongue is the offending structure, or the tongue is the offending structure because it's taking up all the space. We'll get a closer look at the soft palate region. You can see that soft palate snore. Again, you can see it's very much like a clamshell, meaning it's an AP type direction. You don't see the slit or the circle that's very distinct of concentric or lateral collapse. So this guy's got a tongue problem, he's got a velum problem, and it's in the AP direction. So you score this guy, his vote score would be V1 AP, T2. T2 is where the ENT said that he had complete occlusion of the tongue. I don't see it here, but it's possible later on in the study we saw that. We can look at a patient here. This one, I guess there is sound playing on this one, but hopefully it's not too loud for whoever's got the headphones on. Maybe just turn your volume down. But anyway, so you can see this like slit-like appearance, and that's telling us we're lateral walls. And we're going to peek past the lateral walls, and we're going to see the tongue. This in the background, that's the tongue. It's hard to see, but it's very much occluding the airway. So this guy's got a lateral problem. He's got a tongue problem. It doesn't look to have any velum problem. And so if you score this guy, O2 T2. There you go. You've scored an airway. You have some idea of what it should look like and what the corresponding vote score should be. So, the vote score in general, is it, you can see it looks somewhat subjective, and so the question is it even useful? In general, it has been shown to be useful. So, vote scores, anteroposteriorly directed pharyngeal collapse is determined by the vote score, generally is a favorable type of collapse when it comes to hypoglossal nerve stimulation and oral appliance therapy. For reasons I mentioned, that you're pulling the jaw forward, you're moving everything anteriorly, and you're going to open up space behind the airway and treat their sleep apnea. Anytime there's a lateral component, that means that lateral walls collapse or that concentric collapse, which can happen actually higher up in the soft palate, those are going to be harder to treat with these anterior movement type treatments. And so that's what the evidence shows. The only, the thing that where there can be some improvements is the fact that the vote score is a subjective measure, and the fact that getting a DISE study is something that requires a specialized environment with trained expertise, and so these ultimately end up being barriers to non-PAP therapies. And so our approach is to say, okay, can we do this simply and non-invasively? Specifically, can we look at airflow from the clinical polysomnography and then estimate the site of pharyngeal collapse? And so what I'm going to talk about today from the research side is, can we go from airflow signal to then automatically computing airflow parameters from individual breaths, to then estimating the site of collapse from those airflow features, and then predicting treatment response to site-specific therapies using those estimated site of collapse. Now, a big thing here is, okay, well, what's the physiological basis of the airflow shape? Why should I believe that flow shape has anything to do with site of collapse? So I'm going to show you one example of how we linked one particular type of airflow shape to a site of collapse, and then from there we're going to bridge to how we use that to estimate treatment response to hypoglossal nerve stimulation. So generally when we collect this data, there's a couple different paradigms we use. One of them is, you can think of it like a regular sleep study, but the thing that we do differently is we put an endoscope in the airway. We do measure airflow a little bit more precisely than a nasal cannula, but for the most part, all you have to think about is it's a regular sleep study, and then we put an endoscope in the airway. We attach it to an IV pole, and then we ask the patient to fall asleep. Obviously, it's not an easy task, but most patients do fall asleep, and if we can get about an hour and a half, 2 hours, it's enough data. Now, this is a difficult data set to collect, but we still do it because it's, we consider it to be the ground truth. But an alternative, which is very close to the ground truth, is simulated sleep in the operating room using propofol sedation. So this is called drug-induced sleep endoscopy, or DISE. So now what we do is I go to the OR every Friday, I put a pneumotac sensor on over their face, and we measure their breathing while they have an endoscope. And this is all measured in sync, so you can see the airway as you see the airflow. So I'll show you that data. This is the DISE data. We only collect airflow in that. We do collect it in the nose and mouth separately, but it's not necessarily something we'll talk about, but that's the paradigm we're using. So you can see this is the airway. That's how it changes with airflow, and so we can do a nice job linking airflow shape to site of collapse. All right, so what I'm going to talk about now is one particular flow shape that we're very interested in. So I think this is back in 2017. Andrew and Pedro were really interested in this. And on the left, you have a patient with tongue-based collapse. On the right, you have a patient with lateral walls collapse. We're going to look at how the flow shapes are different and why we think they're different. So this signal here is an epiglottic pressure signal. This is telling us how negative is the pressure in the airway. And the negative pressure in the airway is important because that's the thing trying to collapse the airway, right? It's trying to suck the airway shut. In the case of tongue-based collapse, what happens is you take a breath in, there's negative pressure in the airway, but the airway doesn't change shape from the negative pressure because the tongue is a fairly static structure. So what you get is a fixed obstruction. And the airflow looks like this. So you take a breath in, the airflow is limited because the hole in the airway is smaller, right? What the airflow wants to do, it wants to do this, right? But what's happening is it gets caught there because the airway is smaller. Okay, so you get a plateau, and that's just flow limitation. Now there's an interesting case where you try and take your breath, so you try and do this, but what happens is you take a breath, you get to this peak flow, which is actually pretty good. That peak flow is 0.25 liters per second. You might not have sleep apnea, but then with the negative pressure, the airway collapses in on itself. So the airway at the end expiration or the beginning of inspiration looks like this, and then at mid-inspiration, it looks like this. So it shrinks down to this tiny little hole. So you have this peak flow is a representation of how breathing through this airway is like. And this flow, plateau flow, is what it's like breathing through this tiny little airway. So what this airflow is telling us is that we have a compliant structure wherein the airway is collapsing in on itself and turning into this tiny little hole. And it's important to know that the structure is compliant because that certain tissues are compliant, i.e. the lateral walls and the soft palate. So from flow shape, we call this feature negative effort dependence because with the effort, despite the positive effort, you're getting negative results. So it's negative effort dependence, and you look at the peak flow minus the plateau flow, and you do a fraction of peak flow to quantify that. And so to summarize that, with a greater intra-breath flow reduction, so more negative effort dependence, is associated with more tissue deformation with negative pressure, which is a signature of a compliant pharyngeal structure, i.e. the oropharyngeal lateral wall. So we think we have a way of identifying lateral walls. This is some more video. I want to save on time, so I'll just show you this one video oh, that's loud. I can't change the volume on the presentation itself, so I'm not going to show this video to save the ears of the people who are listening at home. And I want to get past these slides without actually activating it. Okay. Unfortunately, I can't show it, but this is a tongue-based collapse, and you can see that the airflow is plateaued. And then, as I said, these are lateral walls collapse, and in these situations, you're seeing the negative effort dependence. So these are just examples to prove to you what we saw was not just one example. It happens very often. But I don't want to play that because it's going to be too loud, and whoever's listening in the headphones is going to get blown out. But we do have some systematic data here. So this is from the natural sleep endoscopy data. Negative effort dependence tends to be lower in tongue-based patients, higher in lateral walls patients. So again, in the systematic data, we do see that this trend is associated with site of collapse. And so, we have a nice flow shape feature that we think we can use to estimate site of collapse. And so the next big step here was to say, okay, can we turn airflow shapes into a site of collapse as determined, by the VOTE score, the gold standard way of determining site of collapse. And, we also wanted to do this in a large data set, right? A lot of these natural sleep endoscopy studies, they're about 30, 40 patient data sets. But what we had access to a larger data set, which I'll describe in a second. So the goal here, and this is in collaboration with Sarah Optebeek and Scott Sands, and this was to develop a model to predict probability of lateral walls collapse from airflow. We're predicting other sites, but we're going to talk only about lateral walls right now. And so I'm going to very, very, very briefly tell you what we did here so that I can just move on to the next part. So we did a retrospective analysis, 162 patients. They had in-lab PSG, so we can get airflow data from them, and then they had clinical DISE, so we can get their site of collapse. Now what that means is we can now link flow shape to lateral walls collapse. So we made that model. We made a model that took 6 flow shape features that very well characterized that negative effort dependence, which I talked about previously. So we took 6 flow shape features that really nicely characterized negative effort dependence and made a model that showed that can predict lateral walls collapse. And what this allows us to do is with new data, we can enter flow shape features into the model, and out of it will come a probability of lateral walls collapse. So we actually have a continuous measure of whether or not someone's having a lateral walls collapse. And so that's all I'm going to talk about there. There's obviously a lot of research that went into that, but just wanted to quickly tell you that we made a model. And so the next thing is to say, okay, let's apply that model to try and predict treatment response to patients that have hypoglossal nerve stimulation. All right, so to give you a little background, patients that get implanted with hypoglossal nerve stimulation, generally what happens is if you have this type of collapse, this complete concentric collapse, you're not eligible for the therapy, and you do not get the therapy. So you actually can't answer the question of, can we estimate complete concentric collapse and see if they do worse with the implant because they don't get implanted. But who do get implanted, among the patients that do get implanted, it's the lateral walls collapse patients. So we still treat patients with lateral walls collapse. Even though it does seem like they're not going to respond, they still can get treatment. And some of them do fine for whatever reason. So I'm not saying they shouldn't get treatment, but what we want to do is identify those patients, and the clinician can manage expectations to say, look, you got this type of collapse. We're not sure how successful it's going to be, and so you can move forward if you like, but these are our reservations. So the idea now is to say, okay, let's try and identify those lateral walls patients and with flow shapes and see if it does indeed correlate with a worse response. By the way, we do know that lateral walls collapse as determined on DISE is associated with worse response. So the surgeon that I work with, Dr. Hewitt, published that a few years back. So that is known, and so the question is, can we do that non-invasively now? So here we are in the pipeline here. We're predicting treatment response. We're going to do three things here. We're going to, first of all, validate the model that Sarah and Scott made. Does flow-shape-derived lateral walls collapse associate with DISE-derived lateral walls collapse? We showed it in that one model, but maybe it's just overfit. So why don't we test it in some new data, which we have. The second thing is, does flow-shape-derived lateral walls collapse predict, or is it associated with HGNS, hypoglossal nerve stimulation, treatment response? And then can we use both flow-shape and DISE-derived lateral walls collapse together to make an even better prediction? You might think, well, why would you use both? Well, you could have a situation where you have the PSG for the patient, you have the DISE for the patient, and so you can put those two pieces of information together, and if it improves prediction, why not? So that's those are the three aims. And the idea here is not to identify patients that shouldn't get treatment, is to say, give clinicians information that they can then feed back to the patient in terms of managing expectations. Here's the paradigm that we use. So the patient does get a baseline home sleep test or a PSG, but it's the clinical DISE where we measure the flow, where we're going to use airflow to predict treatment response. We're not going to use the PSG, partly because it's just not good enough quality airflow data, which is a whole topic in and of itself. So we're going to have a clinical DISE, we're going to have pneumotac flow. Patients are going to get implanted, among other therapies, but if they get implanted, we follow them up with another home sleep test to determine how well they did on treatment. So it's the baseline and the follow-up are just telling us their treatment response, and the airflow and site of collapse is coming from the actual DISE study. As I showed this picture before, this is the DISE study collecting the airflow from the patient there. All right, just to give you some idea of how the data is being processed, we have an automatic way of identifying airflow shapes that we care about, taking the flow shape feature from each of those shapes within each patient, and then getting an average flow shape metric for each patient. So let's say we have 6 flow shapes. We have, for each patient, we have an average value for each of those 6 flow shapes, and then that can be put into the model, and for each patient, you get a probability of lateral walls collapse. So it turns it into a subject level. You go from flow level to subject level. Not to get into stats or anything, but we're just gonna use logistic regression to link DISE-derived lateral walls collapse to the probability of lateral walls collapse. And then we're gonna look at linear regression to say, okay, what's the relationship between flow shape derived lateral wall collapse and the reduction in AHI from HGNS, and we'll obviously control for AHI. We're going to do the same thing with DISE-derived lateral walls collapse, just for comparison. And like I said, we're going to put them together, flow shape and DISE-derived lateral walls collapse. How does that associate with percent reduction? Here's the subject characteristics. Pretty standard sleep apnea population, N of 114 patients, which is actually a very a decent sample size for HGNS patient group. Percent reduction is very high, so either the surgeon is excellent or there's some other reason behind it. The other reason is that we use titration studies as the follow-up, which anyway, that doesn't mean much to you guys, but the point is this value is a little bit inflated, but it's still a good enough signal for us to determine treatment response. It's just, biased to some level probably. And so let's look at AIM-1. So we don't have to think about all of this, but the main thing I'll point out is when we're relating flow-shaped derived lateral walls collapse with DISE-derived lateral walls collapse, you get an odds ratio, you get a significant result, odds ratio about 2.5. So, 2.5 times more likely to be labeled lateral walls collapse per change in probability of flow-shaped derived lateral walls collapse. So this is encouraging. Basically, this model that was produced on a whole different data set, capturing airflow from a whole different mechanism, they use the nasal cannula, actually works on this data here. So obviously, we're pretty pleased that we saw that relationship. And this encouraged us to sort of move on and look at AIM-2. So again, don't want to necessarily get into stats here, but I'm just going to say that when we related flow-shaped derived lateral walls collapse with the percent reduction in AHI, we saw an effect size of 15. So 15 means an additional 15% reduction in the AHI per 2 SD change in the probability of lateral walls collapse. We can look at that graphically. It's a little easier. This is the model here. This is the actual data. This is the data in different patient groups. So if you look at a patient group that has a really high probability of lateral walls collapse, they get a massive reduction in AHI, 90% reduction in AHI in the group that has really low probability of lateral walls collapse. Contrast to the group that has a very high probability of lateral walls collapse, they do much, much worse. They have almost a 50% reduction. So again, in terms of talking about managing expectations, this is the group where a clinician would say, okay, look, it doesn't look too good for you in terms of how well the HGNS is going to treat you, but it's something that you can pursue if you're interested in, but I want to manage your expectations. Again, you have this middle group that I would say these are like why not go on to treat, and this would be a needs further evaluation / manage expectations. I don't want to take up too much more time because we're running low, but I'm very quickly going to say we did the same thing with DISE-derived lateral walls collapse. Actually, what time is it? Am I actually running low on time? No, it's 12:40. Good. So DISE-derived lateral walls collapse versus, DISE-derived lateral walls collapse versus no lateral walls collapse. And so you only have these 2 patient groups because you have a group that doesn't have lateral walls collapse as determined on DISE and a group that does. And you see that the group that does has a worse treatment response as we expected. But the thing that's a little bit less favorable about this is that, when you look at probability of lateral walls as a continuous metric, you had these sort of higher certainty groups. They were smaller, but there was higher certainty that they would respond. These sort of end up a little bit middling in terms of the certainty. And so, I find that with the flow-shaped derived side of collapse, given that the effect sizes are similar, I think the paradigm that might even, I would consider to be even preferable is the flow-shaped derived side of collapse, which is saying something. And now the question is, can we combine them together? Do we get some better prediction if we combine them together? And again, combining them, you can think of combining them as there's actually a clinical tool here, which is that, let's just say you do the flow-shape-derived site of collapse first. You determine they're in the group that needs more assessment. So in that needs more assessment group, you actually do the DISE. Now you have DISE and airflow, so you would want to put those two values together to get a better prediction. There's no point in now ignoring that previous information you collected. So that's the reason why we put them together. So here you have, this is the effect size for the DISE flow-derived lateral wall collapse. This is the effect size for the DISE-derived lateral wall collapse. So if I were to distill that into a sentence, you get an additional 13% reduction in the AHI per 2SD change in the probability of flow-shaped derived lateral wall collapse after adjustment for the DISE-derived. So now the point is that each of them do provide value. So they have some unique variance, each of them, which means that partly that they're not correlated with each other perfectly. Which also means there's work to be done in understanding this flow shape a little bit better. But you can see as we move from low probability to high probability of lateral walls collapse, that you get that same drop in the percent reduction in AHI. So you can see that this group here is almost like move on to treatment. This group here needs further assessment, and you get a little bit more information when you add the DISE-derived lateral walls collapse. So this is the gray box here is if they were determined to have lateral walls collapse on DISE, and so essentially you get an additional 10% drop. So you can argue it's like maybe you have this group here that's like, probably wouldn't treat. Maybe this group here is like manage expectations, and then this group here is move on to treatment. I mean, obviously that's up to the clinician, but the idea here is we're providing a lot of additional information for the clinician to make treatment decisions. So I'll end it there and just say that so far we've developed some interesting flow shape metrics that on their own have, as well as an adjunct to DISE, have shown to be a promising tool to enhance pharyngeal assessment for treatment decision making for the ENT surgeon or potentially for even sleep clinicians more broadly. And then the next step is, as I said, we looked at flow shapes from the DISE. We want to look at flow shapes from the PSG. It's just a matter of getting sleep studies that give us a decent nasal pressure signal, which is actually harder than you think to get. A lot of the sleep studies, in case there's anyone who's interested in trying to solve this problem, a lot of the sleep studies, they put a high pass filter on their nasal pressure signal, and it basically ruins the airflow, especially the shape. It distorts it. So we want to move on to doing the PSG derived, and then of course snore sounds is a topic that's of significant interest in the context of site of collapse. We are measuring a snore signal. We even have a little model that detects site of collapse from snore sounds, and it does a pretty good job. But at the moment, flow shapes continue to win out in terms of predicting treatment response. And again, when I say we need to learn more about that flow shape, I think it's something to do with the compliance of the tissue that goes beyond site of collapse. Because within site of collapse, you probably have various levels of compliance. And I think what we're measuring is that the high level of compliance is just hard to treat with non-PAP alternatives. All right, I'll end it there. Thank you.
Are there any questions in the room? Raise your hand. In the meantime, and then maybe guys, can you repeat the question?
Yes, I will. Which one?
This one.
Yeah.
Oh. So, question. This is I mean, the audience can see it, right? So, when you look at these measurements, I mean, you have it from a scale of 40 to 100, but they're fairly close to each other.
The percent reduction.
For example, the middle recordings and the right ones.
Yeah.
So how, and when you measure them between in the range, so how certain are you that you're in this group and not in that group?
So in terms of what?
Just from my personal education.
Yeah. So, okay, so I think that let's look at the flow shape model just because it's a little bit, it's a similar thing without looking at the two different bars that are going to confuse us. If you end up in this group here, okay, so you end up in this group here, your treatment response is about 90, but you know, in the population, the percentiles range from about 75 to almost 100, almost perfect treatment response. Now you have, I'm comparing these two groups because these are the ones where I'm saying, you know, you have this nice level of you know, this nice differential between them. So now here you have this group that's at about 55% reduction. There is a decent range, but again, the median patient is at 55. So we're talking about a, you know, this patient here, their sleep apnea can drop from 40 to less than 10, okay? This patient here, the median patient, is gonna go from 40 to 20. So that information needs to be given to the patient. As a patient, are you comfortable with a therapy that you're still gonna end up, we're gonna do a surgical treatment on you, but you're still gonna have moderate sleep apnea? Are you okay with that? So that's sort of the value here, is adding that bit of information. It's not to say, oh, this group, don't treat them. My model says don't treat them, and it knows all, and it's information for the clinician. Right now, the clinician uses the video itself, and the error bars in the video is even bigger, but they use it. So why not use something where we can make the error bars even smaller, and it's even easier to collect? That's sort of my pitch. Yeah.
I'm going to read a question from Dr. Catriona Steele, who's asked this online. Were the endoscopy examples obtained with the patient lying supine or sitting upright? Are upright views and exams valid for caption collapse patterns that occur while supine and not alert?
Oh, that's a great question. So patients are supine. We're simulating sleep. For better or for worse, we keep them in supine. Even if you have a side sleeper, they do get put on their side very briefly for the surgeon to take a look, but generally speaking, all the patients are supine. When I say better for worse, the good thing about that is we control position, so we're not sort of, you know, worried about what the effects of position are. We don't ever really look at the DISE in the patient in an upright position, just because we are doing our best to simulate sleep. I don't know of any. I guess there could be patients that are sort of, you know, semi-recumbent, but generally most DISE that I've come across, patients are supine. However, there is a situation where patients get endoscope while awake. Now, I would say that, you know, once you talk about wakefulness, endoscopy videos, it's a little bit harder to determine the site of collapse. There is a study out there that shows that if you simulate oral appliance therapy while the scope is in the airway, and evaluate how the airway changes with that simulation, that it does have some predictive value in predicting treatment response. So awake data, I wouldn't say is not useless by any means, and it is useful in some contexts. But in detecting site of collapse, I haven't really seen anything out there that links it. But I'm not sure if you were asking about wake, but if you're just asking for upright sleep, we don't study that, but it is an interesting area in terms of determining therapeutic benefit, I guess.
There's another question online from Dr. Yadulahi. She's asking, have you looked at the relationship between the level of negative intrathoracic thoracic pressure and shape of airflow?
Negative intrathoracic pressure and shape of airflow. It's a good question. So, like, you could probably argue that as you move through the respiratory event, that you're getting more negative pressure. So you can imagine that intrathoracic pressure gets more negative as you move from here to here. And the reason I actually like that question a lot, because what we've done is sensitivity analyses to controlling for the amount of airflow So let's say in this event, if we say, okay, let's only look at breaths that are bigger than X, well, then we would only look at this breath and this breath, let's just say. And that's by controlling for that, we're essentially controlling for negative pressure. And I do find that it's the breaths that have higher ventilation that have more information about the site of collapse. And one of the reasons that I think is that when you get to this level of really high intrathoracic pressure, you kind of suck the airway too far shut, and you limit the amount of information from the flow shape. So we haven't formally evaluated that, but the within event changes in negative effort dependence, let's just say how scoopy this breath goes through the event, is a very interesting question, and probably will also give us another measure of the compliance of the airway, which, if my assumptions are right, which is that all we care about is compliance and less about site of collapse, then that relationship with intrathoracic pressure will be an important one. So yeah, that's a great question. Thank you.
Thank you. There's a follow-up question from Dr. Steele, and she says, thank you. How do you control for depth of the scope into the airway for being confident that you are comparing the same locations across patients or across successive studies in patients? And she says, I ask because in endoscopic swallowing exams, we want to be able to measure depth of the space or material in the view, but calibrating exactly where the scope tip is seems to be very challenging.
Yeah, very good. Yeah, that's a nice question. So the funny thing is that the vote score itself doesn't even accommodate for that level of specificity. So when we're using our ground truth, measure of site of collapse, we use the vote score. I'll give you an example. If we talk about that, I just want to show the vote score so that we're on the same page here. So it's V, O, T, or E. Now, if we have a patient, in my study where I said lateral walls collapse, a lateral walls patient was defined as a patient that was either O1 or O2 and no T2. And the reason is because the previous research showed that as soon as a T2 accompanies a lateral walls, there is some therapeutic benefit. So we don't consider those to be non-responders. So it's O2, T2. Now, the only reason I'm telling you that is because that's the level of specificity that we have in determining site of collapse. There is additional specificity that would probably be a great avenue of research, which is, if you have a lateral wall that's collapsing along the airway over a larger segment rather than over a small point. One way of detecting how long of a segment your lateral collapse is the fact that if it's laterally directed in the velum and it's laterally directed in the oropharyngeal lateral walls, that's what's called complete concentric collapse, and that means it's collapsing laterally along the whole length of the airway. And that's actually a predictor of non-responder to hypoglossal nerve stimulation, and in fact, those patients don't get implanted. But indeed, if we look at those patients' airflow shapes, they have the same pattern. They have that negative effort dependence pattern. Now, anyway, I'm just a long-winded way of saying we don't actually look at the airway in that level of specificity. If you look at enough of these videos, you start to get an idea of the handful of 6, 7 patterns of collapse that you see. So that's as far as we go. But in terms of strengthening our ground truth measurement of site of collapse, I think there's lots of room to grow in that direction. But I haven't heard of anyone taking the torch on that. But it's very interesting.
Thank you. Before we wrap up, there's a final comment from Dr. Yadullahi, who says they're very interested in whether the shape of airflow can be associated with negative interthoracic pressure. And she's saying if you're interested, she's also interested in collaborating.
Okay, Azadeh said that.
Yes.
Okay.
Okay, I think we're closing out in time, so let's thank our speaker. one final round. Thank you.
All right.
Is that okay? Okay, this one is from Riemann Marzuka, and she's saying, we know that OSA is often the worst during REM sleep because of reduced muscle tone in the upper airway that naturally occurs during REM sleep. Measurements from DISE represent a small part of the night and cannot give information about the REM sleep phase. How are you addressing this limitation in your studies?
Nice. Yeah, a lot of really good questions. Sorry, can you read the first part about the muscle?
It says, we know that the OSA is often worst during REM sleep because of reduced muscle tone in the upper airway.
Okay, perfect. So we have natural sleep endoscopy data, which in theory there should be some REM during while we collect that video. In practice, I don't think that's going to happen. Like, I highly doubt a patient's going to get into REM sleep when they have a scope in their airway. You know, it's just a limitation of natural sleep endoscopy. And then, of course, the limitation of drug-induced sleep endoscopy is that it's really hard to, possibly impossible to simulate REM sleep. I'm not sure. I mean, you could argue that with propofol sedation, that muscle tone is lower. So you could argue that we are looking, their airway is behaving more like a REM airway than a non-REM airway. I have no idea. I'm just speculating. So now when it comes to looking at negative effort dependence during REM sleep as it pertains to site of collapse, I mean, in theory, we could just look at what type of site of collapse they have and then see how the negative effort dependence differs between REM and non-REM. We haven't looked at that. There is somebody at, I think, UC San Diego that's doing a deep dive on negative effort dependence. So probably in the next year or 2 years, we're going to see some literature on, you know, how negative effort dependence within the breath is related to negative effort dependence across breaths, if that makes sense. How that relates to intrathoracic pressure, like Dr. Yadulahi was saying, and then how that differs between REM and non-REM. The sort of my intuition is that when you have in a non-REM, if you have, let's say, lateral walls collapse, if you have negative effort dependence in non-REM, your muscles will be even quieter during REM, and maybe it turns into complete collapse, or the negative effort dependence is even more dramatic. Or you can imagine in an airway that might not have negative effort dependence during non-REM might get it during REM because, you know, the tissues in the side walls where maybe the muscle tone goes down and they become more compliant. So intuitively, the idea is that you know, when I talk about negative effort dependence as being a measure of more than just site of collapse and a measure of tissue compliance, I'm implying there that we are measuring muscle tone as well as, you know, phasic muscle activation, you know, such that patients with really bad muscles in the airway are having more negative effort dependence and they're really hard to treat. So that's kind of, I am sort of, you know, moving toward this idea that, you know, muscle tone and negative effort dependence go hand in hand, and REM versus non-REM would probably be a good paradigm to study that. Thanks.
Okay, so this time for real, we're going to thank the speaker again and wrap up the session. Thank you.